Welcome to Docquity. My name is Dr. Tamil Selvan. I'm a consultant cardiologist from CVSKL Sentral, Kuala Lumpur. Today, I have the pleasure of giving a small lecture on heart rate and cardiovascular outcome. Without further ado, I would like to move on to my first slide. We are going to cover in this lecture epidemiological evidence of heart rate and cardiovascular outcome. We are going to cover clinical trial evidence with association of elevated heart rate and cardiovascular outcome. And looking at these data, we will see if there are any subgroups which are at risk, in particular with elevated heart rate. And we would also look at evidences for clinical benefits of heart rate reduction with beta blockers, and we will see why we need other modifying agents to improve cardiovascular outcome, in this case in particular ivabradine, another heart rate reducing agent. And the elevated heart rate has a pivotal role in cardiovascular disease and outcome. As you can see on this slide, an elevated heart rate gives rise to increasing oxygen demand, and this leads to ventricular inefficiency, prolonging ventricular or abnormal ventricular relaxation, which in turn leads to chronically may lead to heart failure. And heart failure in itself as part of this neurophysiological reperfusion, therefore further affecting the efficiency of the heart function. On the other hand, a heart failure in itself due to neurohumoral modification increases heart rate, and on the other hand, increasing heart rate in itself on a chronic basis can lead to heart failure in itself. And the whole situation leads to increasing oxygen demand and poor ventricular function. And this interplay is important in the pathogenesis as well as the outcome of the cardiovascular disease. Let us first look at some epidemiological evidence for associating increasing heart rate and cardiovascular outcome. The most well-known one is a Framingham study, as we all know. It's a long-term study which has given us a lot of insight into cardiovascular outcome. In this particular case, as you can see on the slide, the long-term cardiovascular risk was evaluated on this particular trial, and you can look, the heart rates were divided into different quartiles and starting from low heart rates to very high heart rates. And the association of baseline resting heart rate and cardiovascular outcome in this particular analysis showed on a multivariable adjusted model, you have a 15% increase in cardiovascular disease outcome, and in particular you could see there is a 32% increased risk of future heart failure, and this is seen for every 11 beats per minute increase in baseline heart rate. So there is a strong association between cardiovascular disease increment and in particular heart failure. If we look at the same analysis and we look at the age and sex adjusted model, and you will find that in particular heart failure becomes a prominent outcome that is seen with an adverse increasing heart rate. There is definitely a twofold increase in risk of heart failure in the top quartile, which is patients who are above 80 beats per minute. And in this particular analysis, there appears to be a 17% increase in risk of all-cause death as well. Now, one could say this is a Western population data, and what about Asian population? There is a trial which is shown here, heart rate influence of incidence of cardiovascular disease among adults in China. And to summarize this, the higher the heart rate in this particular trial, you can see the survival rates were lowest. and this is true for both men and women. And one can, from this particular study, epidemiological study, one could make an assessment or conclusion that elevated heart rate is associated with high cardiovascular disease in Chinese adults. High resting heart rate is an independent predictive risk for stroke in Chinese adult male. And in this particular trial, heart rate of more than 90 beats per minute increased risk of coronary heart disease in Chinese adults. And to further support this association of heart rate and adverse cardiovascular outcome, we have a two comparison of survival rates due to cardiac events in a Japanese population. This is plotted on the left, and you can clearly see the best survival are seen when the patient's heart rates are lower, particularly below the 73 beats per minute, between 65 to 60 beats per minute. And the risks are higher in the higher quartile, more than 78 per minute. And a similar survival probability curve shows among mortality in French men, and this is a large trial almost involving 12,000 patients. As you can see, the higher the heart rate, the lower the survival probability. Again, telling us that increasing heart rate has an adverse cardiovascular outcome. And these are epidemiological evidence that I would like to share with that I have. But let's take a look if there is more clinical evidence for this association. I would like to start off by looking at post hoc analysis of almost 10,000 patients from a TNT study, which was a statin study, and there was a follow-up of almost 4.9 years. And here, the resting heart rate was a predictor of prognosis in patients with stable coronary artery disease. As you can clearly see here, in terms of all-cause mortality, heart failure hospitalization, major cardiovascular events, and in fact, non-fatal myocardial infarction were all shown to be adversely affected if the heart rates were more than 70 beats per minute. In this particular analysis, the groups were divided into heart rates less than 70 and heart rates more than 70. As you can clearly see, all aspects of mortality, hospitalization, major cardiovascular events, as well as non-fatal myocardial infarctions were higher when the heart rate was more than 70. And a similar analysis was also taken from another trial, which is a beautiful trial. Beautiful trial was a trial involving ivabradine to look at outcomes of controlling heart rate with the use of ivabradine in patients with stable coronary disease but with poor LV function, in other words, stable coronary disease and heart failure. This particular analysis looked at the placebo group, and there were almost 5,000 over patients in this particular group, and an analysis was made based on heart rate between less than 70 beats and more than 70 beats. Here you can clearly see there was a significant 34% increase in cardiovascular death. There was a very significant over 50% increase in hospitalization for heart failure in this particular group, particularly in those groups with heartbeat more than 70 beats per minute. And percentage of hospitalization for fatal and non-fatal myocardial infarction was also significantly elevated, as you can clearly see this graph. And if we were to look at other trial data, you will remember on target and transcend data. These are hypertensive patients, male and female, 55 and above, with high risk of cardiovascular disease. Either they've had coronary disease or at high risk of developing coronary disease, and these patients were in the trial. And here there was an assessment to look at heart rate as a cardiovascular outcome marker, and it showed a very interesting data. Whether you are a diabetic or a non-diabetic, there appears to be a nadir of beneficial heart rate, as you can see, between 60 to less than 80 beats per minute. But the best results are seen in patients with less than 70 beats per minute, where the cardiovascular outcome is lowest. But on this analysis, there appears to be also U or rather J-shaped curve with regards to heart rate when the heart rate, the cardiovascular events were higher when it falls beyond, below 50 beats per minute. And if you were to look at CHARM study, it's a study involving patients with heart failure with reduced ejection fraction and preserved ejection fraction, and an analysis looking at resting heart rate with regard to cardiovascular risk factor. We found that for every 10 beats increment in the heart rate, there was a respective increase of 8% in all-cause mortality. Again, in these patients, whether you have heart failure with reduced ejection fraction or preserved ejection fraction, the resting heart rate appears to be a predictor of outcome in heart failure. So, based on this, and I've summarized that cardiovascular outcomes are associated with elevated heart rate. There appears to be a very prominent group of heart failure patients who are particularly have adverse outcome if the heart rates are elevated. And what about those patients with coronary artery disease? I think we can make a two assessment here, and those with patients with heart failure and those without heart failure. I will touch on this a bit more further on my lecture. What are the clinical benefits of reducing heart rate? We have seen a clear association of elevated heart rate with regards to outcome, and now we want to know, by reducing this heart rate, do we reduce the adverse cardiovascular outcome? And beta blockers, as we know, are one of the biggest commonest drugs that we use in terms of bringing the heart rate down. So we will look at some evidence of beta blockers, particularly in heart failure trials. We're going to look at other trials involving other drugs such as ivabradine, which are also rate reducing drugs, and we will touch on patients with pure heart failure, patients with stable coronary disease but with heart failure, and patients who have stable coronary disease without heart failure. And the SHIFT, Beautiful and Signified trials are examples of the trials that I would discuss. We all know that beta blockers and reducing heart rate is a very important aspect of modulating neurohumoral activation in any heart failure. And you can see that increment in the sympathetic activity, increases vasoconstriction, stimulates RAAS activity, increases vasopressin, increasing heart rate, increasing contractility, and over a long period of time, these initial compensatory mechanism becomes rather adverse to the heart and leads to adverse prognosis. And the impact of beta blockers in heart failure is very well known, as all of you by now will clearly understand. And this is a summary of trials looking at changes in heart rate versus mortality in drug intervention in patients with heart failure with reduced ejection fraction. These are some earlier trials with using isosorbide dinitrate and hydralazine drugs, and VHEFT patients using prazosin and PROMISE trial, compared to the results outcome where you can see beta blockers usage to reduce heart rate. And you can see a significant reduction in mortality in all these trials using beta blockers as a mean to reduce heart rate, as a mean to intervene on the neurohumoral modulation that happens in heart failure. And you can see the profound reduction in mortality with the uses of this drug. An example will be a CBS2 bisoprolol trial. As you can see, within a mean follow-up of 1.3 years, you could already show a significant reduction in morbidity and mortality in this trial. And you can see that the effect of different agents of drugs which all work differently, addressing different neurohumoral modulation in reducing event, and beta blockers have a profound effect on the outcome. But despite the best of efforts, we still see that very high mortality Almost 50% of the patients die within 5 years of diagnosis. So there is still a lot to be done. And how can we do this in terms of reducing heart rate? I'm now going to show you ivabradine in some various landmark trials. We talked about, I'm going to talk about these 3 trials briefly, and shift, we're going to talk about heart failure and the use of ivabradine in addition to beta blockers. Beautiful trial, a patient with stable coronary disease with heart failure with regards to trying to reduce the heart rate with the use of beta blockers and ivabradine. Signify is similar trial to beautiful, but however these patients do not have heart failure. And you can see the SHIFT trial is basically patients with class 2 to 4 New York Heart Failure Association classification. They could be either ischemic or non-ischemic, but more importantly, they had left ventricular systolic function less than 35%, and those with heart rate more than 70 beats per minute in sinus rhythm were included. As you can see, the primary composite endpoint here was cardiovascular death and hospitalization for worsening heart failure. And there were other secondary endpoints, as you can see here. In total population and patients with at least 50% target dose of beta blockers were used in this trial. As you can see this, in chronic heart failure, the background treatment here are quite good in this particular trial. In particular, you can see almost 90% of the patients were on beta blockers, and a very good number were receiving either ACE inhibitors, ARBs, mineralocorticoid antagonists. And the usage of beta blockers here shows that at least 50% of the population were receiving a maximum, only 50% of the patients were receiving at least 50% of the target dose of beta blockers, and only a quarter of 25 to 26% were receiving the maximum target dose of beta blockers. As you can see that in this particular trial, compared to placebo group where only beta blockers were used, in the active arm, usage of ivabradine showed a significant reduction which was well maintained throughout the period of the trial and safely, and the heart rates were significantly reduced below 70 beats per minute with the use of ivabradine. And this is the primary endpoint, which is cardiovascular death or hospitalization for heart failure, were highly significantly reduced. There was an 18% relative risk reduction in the primary endpoint. And in terms of hospitalization for heart failure, there was a highly significant 26% reduction, which was very significant indeed. Although the all-cause mortality in this trial was not significantly different between the two arms, but the death from heart failure was significantly reduced by 26%. And as I said, the all-cause mortality was not significant, but primary endpoint, death from heart failure, all-cause hospital admission, any CV hospital admission, and CV death hospital admission for heart failure or non-fatal MI were all significantly reduced, showing the benefit of ivabradine, particularly if the heart rates were high in this particular subgroup of patients. In beautiful trial, these are patients with stable coronary disease and heart failure. You can see that in patients with above 70 beats per minute, there was an increased CV death of 34%, increased heart failure admissions of 53%, increased MI admissions of relative risk of 46%, and also increased coronary revascularization. I must emphasize, in beautiful study, the primary endpoint was not significant. The secondary endpoints showed possible benefit in reducing heart rate, in reducing possible coronary events, but I must emphasize once again, this is a secondary endpoint. Ivabradine reduces hospitalization, fatal and non-fatal MI with an absolute risk reduction of only 4.6%, and this is a secondary endpoint. Signify is another trial with chronic stable angina, but these patients have normal LV function. As you can see, the primary composite endpoint here showed that rate reduction with an addition of ivermectin should not to be superior to placebo in this particular trial. Heart failure is a leading cardiovascular reason for re-hospitalization. As you can see, in many centers of the world, many parts of the world, heart failures can sometimes account for almost 46 to 50% of reason for cardiovascular cause for hospitalization. And one of the main challenges is every heart failure related hospitalization leads to reduced survival after each readmission. And if you look at long-term registry, you can see that there are many comorbidities or independent predictors among the heart failure patients, and you can clearly see that more than 50% of patients in this particular registry showed an elevated heart rate, which is modifiable. We have seen that that can reduce hospitalization and therefore eventually may reduce death. We know that beta blockers are the number one agent in reducing heart rate in particularly patients with heart failure, but there are limitations. And what are the limitations? Really, despite the maximum dose in patients being given maximum dose in patients with heart failure, that many of them will show that the heart rate is inadequately controlled. The other major limitation is the inability to prescribe maximum dose due to intolerability, either letharginess or low blood pressure or other comorbid conditions that the patient may have. And in many of these trials, we know that we are able to use beta blockers more than 90% of the patients. But however, that in many of these trials, if you look at carefully, that the maximum dose is only prescribed to a quarter of patients, and many only on 50% of the beta blockers dose that is then the target dose. And we know that each hospitalization leads to reduction in survival. And what is important to recognize is the heart failure hospitalization in the first month appears to be very high. As you can see, almost a quarter of patients in this particular analysis were readmitted. Now, in any hospital, one of the pressures that people have is to let the patients go home early so that we have enough beds for the patients coming in with disease for the future. So therefore, there is a small window of opportunity for maximizing beta blockers dose, which is not very often successful. So a lot of the times everywhere in the world that we see that many patients with heart failure hospitalization are discharged home on a much lower dose of beta blocker, simply because we did not have the chance to maximize the dose, and therefore this could impact on the readmissions in the first 30 days, which will then eventually lead to increased mortality. And in this particular analysis, in the randomized ethics study, and if you see early use of ivermectin in addition to beta blockers, not only is safe, that you actually achieve a much better heart rate control. As you can see here, if you look at the magic rate of 70 beats per minute, a combination therapy with beta blockers and ivermectin at discharge significantly reduces the heart rate, and our data so far has shown that reduction in the heart rate will reduce rehospitalization, and this benefit is also maintained beyond that. Now, the important thing is in the early days that we have not had a chance to maximize the beta blockers. So therefore, a combination therapy is a wonderful opportunity to reduce hospitalization. But months along, and when you've had chance to maximize the beta blocker, then you can decide whether the ivermectin is required or not. So, ladies and gentlemen, I would like to conclude the following. Elevated heart rate appears to be an independent risk marker for poor cardiovascular outcome. Cardiovascular death, heart failure events, coronary events are adversely affected by high heart rate, and in the Chinese study, including stroke. These elevated heart rate and the cardiovascular outcome appears to be absolutely pronounced in heart failure patients. Heart rate reduction with beta blockers has major impact in heart failure outcomes. They reduce morbidity and mortality significantly. But however, beta blockers has limitation. This limitation is overcome in some respect by addition of rate reducing agents such as ivabradine to further improve cardiovascular outcome. Early combination of beta blockers and ivabradine is safe and will reduce early events, will reduce early readmission to the hospital. In patients with stable coronary disease with heart failure, there may be a possible benefit in reducing coronary events when heart rate is reduced using beta blockers and ivabradine. In stable coronary disease without heart failure, there is no appreciable benefit that we can document at the present moment that heart rate reduction with beta blockers or ivabradine has been beneficial. With that, I'd like to thank you for your attention.